We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, HHIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
Hey, Jess, how are you doing?
Good, how are you?
I'm good. Hey, do you have any more jokes for me?
As a matter of fact, I do. Did you hear about the germ?
No.
Oh, never mind. I don't want to spread it around.
You're the queen of cheesy germ jokes. I love it.
That's right.
Well, thank you for that. Well, speaking of not wanting to pass things around, we're still talking COVID these days. And today we're going to talk about an often overlooked group when it comes to celebrating our frontline heroes. How does that sound?
That sounds great.
We are talking to Dr. Zainab Osakwe, who is an assistant professor at Adelphi University College of Nursing and Public Health. Her clinical and research career is dedicated to access and quality of care in the home healthcare setting. Her current work focuses on home health aid information needs on patient care plans, particularly home health aides with limited English proficiency. As a nurse researcher, she has leveraged national data sets to investigate quality of care in the home healthcare setting. Dr. Osakwe has published widely on the topics of long-term care, health disparities, infections in the home healthcare setting, including COVID-19. Zainab received her PhD at Columbia University School of Nursing, Master of Science in Nursing at University of Medicine and Dentistry, New Jersey, and BSN at Adelphi University. So we're so pleased to have you. Thank you so much for joining us, Dr. Osakwe.
My pleasure. Thank you.
So this is a really interesting paper, and it's scary to read it because it's talking about home health aides going in during the pandemic and feeling isolated and alone. It's a scary feeling. So we're going to talk about your paper and kind of discuss the three themes that you talk about in there.
Okay.
Which is being all alone and having limited access to information and resources and dilemmas related to enhanced precautions. Those seem to be the three themes that you discussed in the paper. So we'll just jump right in, okay?
Okay. Thank you.
Yeah. So, home health consists of nurses and therapists and social workers and home health aides, or HHAs as we might call them. You focus specifically on HHAs in this paper. Why is that?
In this paper, we focused specifically on home health aides, also called HHAs, specifically because home health aides consist of the frontline direct care staff in a home health care setting. The major role of home health aides, particularly in the midst of this pandemic, is prominent and critical because while there was massive workforce changes and shortage of healthcare personnel, home health aides who are key to providing patients who are homebound direct essential care, such as assistance with activities of daily living, bathing, eating, walking around, and support with basic medication management were really necessary to keep our homebound older adults safe and at home during the pandemic. It was key to gain insight into what their perspectives were and experiences were because during the pandemic, they were the only staff that really had, if there was an elderly patient in the community, they really had to be there in order for patients to perform basic everyday tasks or needs such as toileting. So getting to understand how they navigated these circumstances and close proximity of work that they performed in a patient's home environment, while the rest of the country and at large, the world was really thinking about and still hovering on what's the best infection prevention process around COVID, was really critical to understand what their perspective was about around infection prevention, what their perception of their risks to getting this infection was, and what kind of circumstances they navigated in maintaining infection prevention and control in the home environment. So we really had to go directly to reach out to them because they provide the largest amount of care to homebound older adults in the U.S.
Right. And I know that there are some unique difficulties that HHAs faced that staff working in hospitals and other outpatient settings didn't face. But first, I want to know if you can tell us more about the demographic of these groups. So I know that HHAs are mostly members of marginalized groups, and I wanted to know if you could expand on that and talk a little bit about it.
So it's really important to the context to HHAs was really also key to why we reached out to them directly for many reasons, not just their role in providing large amounts of care and being in close proximity with patients, but also the fact that they are, as you mentioned, a marginalized group themselves with clear demographics that are reflective of an average medium income of about $17,000 a year. They're predominantly poorly compensated, very financially vulnerable workforce. 9 in 10 home health aides are women, and 3 out of 5 are people of color. And there's a large proportion of them that are also immigrants. In particular, to our study, we also purposefully attempted to reach out to home health aides who are also Spanish speaking with limited English proficiency. Within the setting of New York, this group of home health aides are really key because of the large and diverse population that the New York metropolitan area serves. So just getting to understand the home health aide, in addition to other social contexts and social demographics, social determinants of health that also impact them as a workforce, was really essential to our conversations and qualitative approach in this study.
So how do you think that the workers who have English as a second language, what were some of their unique complications?
So as a huge portion or insight that was gleaned from this work is that, unlike we expected, Spanish-speaking home health aides had more complexities in navigating the provision and delivery of care during the COVID-19 pandemic. So while they, yes, had this limited English proficiency in just managing routine conversations, we also noticed that receipt of information about infection prevention and control was really a cause for a little bit of concern. The shortage of interpreter services, which was expected because we were in a pandemic, and it's something that's well known and well documented in the US healthcare system, can be a little bit of a challenge, but particularly in the home health care environment, not having set up or standardized protocols around dissemination of information in times of emergency did have an impact in their receipt of information, receipt of support while working during the pandemic, and also communication difficulties with patients in the midst of the pandemic. So this further raised more concerns about this long-standing marginalization of home health aid workforce during the pandemic. So their voices definitely needed to be heard in order to better prioritize infection prevention and control approaches in the home health care setting. And I'll tell you one thing, this is not, the pandemic only exacerbated these concerns. These are long-standing concerns and things that still points to the fact that more work certainly needs to be done around streamlining and better updating or thinking about a new way to further integrate and prepare, specifically in terms of infection prevention and control processes that are tailored to the needs of Spanish-speaking home health aides that have limited English proficiency and are a key and essential part of our home health aid workforce.
So just to expand on that a little bit more, with regard to education, so it looked like only 36% of the respondents had a high school degree or higher. And then there were also a lot of comments, it seemed like, from the respondents around the desire to get more education around the infection prevention, mitigation, and COVID-19. Can you just talk a little bit more about what their concerns were and how you think that their limited education may have affected them during this time?
What's important about our work, again, is that we were able to better understand what their interests were around the use of potential interests towards the use of technology in working on a regular basis, not just during the pandemic. From our conversations with home health aides, both English speaking and Spanish speaking, there was clear interest and ability to use technology to facilitate communication. The requirement to be a home health aide is a GED or a high school diploma, and that's just what the standards are. Most of the training that is received prior to getting certification, and then on a regular basis by the specific agencies, and there are definitely annual in-services that are provided in that regard. I'm not sure if that has answered clearly what your question was.
Yeah, I mean, I definitely think that it seemed like they were looking for more education on a day-to-day basis. And it also sounded like some of them were receiving some education through those virtual methods, but that others were almost getting nothing. And I imagine that was very scary for them.
Our participants clearly voiced the need to really know what's going on, because the home health aides we interviewed were predominantly individuals who worked at during the peak of the pandemic, and that anxiety and fear of feeling all alone was really very clear and reflected in all our interviews. And the sense of all alone, which is the topic of our paper, was a reflection of the fact that they felt all alone in terms of not having enough information, being all alone and not feeling integrated to the rest of the healthcare team, and not just knowing what home healthcare, the larger home healthcare system, was doing in terms of COVID. So it's not that there wasn't infection prevention control and information being shared in home health care agencies. It's that the aides, who are typically have consistently voiced concerns that they felt less integrated to the rest of the healthcare team, did not feel so connected to the information that's disseminated and information related to infection control and management during the pandemic.
And that makes me question, did those agencies have clearly written policies and procedures? Are you aware of that?
I'm absolutely sure that the agencies had very written policies and procedures that are clear. It's also very important to emphasize or highlight that these concerns of home health aides not feeling integrated to the healthcare team,
right,
not receiving enough information or communicated with, are not new concerns specific to the pandemic. Although they may feel a bit more amplified because we were in the midst of a pandemic, but there have been ongoing challenges that have been voiced by prior researchers that have sought to better understand what the perspectives of aides are in working in healthcare.
Well, thank you for looking into this then, because it looks like this study gives a lot of insight into the emotional and communication needs of home health aides that were previously unaddressed. Like you said, this has been a problem that's been lingering for a while, just exacerbated by the pandemic. And I wonder why. Why did the pandemic kind of exacerbate and shed light on this?
So one thing that's clear is that it was a pandemic. We did not plan for a pandemic. And while every home health care agency has an emergency preparedness plan, right? That's something that's written down and it's outlined and it's expected. There are there are mock drills that are performed annually in home healthcare agencies, and knowing what the emergency, to ensure that home care staff know what the emergency preparedness plan is. No plan, however, has prepared for a pandemic similar to what we faced with COVID. A big concern about COVID-19 pandemic is that with the rapidly change in information and rapid change in dissemination of that information, one key issue was highlighted, and that's the fact that clear processes have to be set up for not just for pandemic related reasons, but for information management and dissemination in general with home health aides, right? So in home health care, in the delivery of home health care, aides work in a very decentralized manner. There's one central office, and then they see patients in the community inside these patients' homes. And when there is an emergency, there's a very strong need to connect to everyone and ensure that information is disseminated at the same time. Many of our aides also did raise very positive remarks in terms of the use of text messages that their agencies used to screen them for COVID, daily screening. And that was something that was a very helpful take back from this study, that the use of that text messaging services that many agencies had already had in place was something that was helpful for aides to actually connect to their agencies and know that some kind of screening is going on. There's definitely a need to leverage or optimize the use of text messaging systems and other information technologies to really connect to thousands of home health aides out there that are taking care of patients. Because that need for reintegration and connection to the central home health care office is really key. And I think that's really highlighted and underscored during this pandemic.
Yeah, that's definitely interesting. I remember some mention of the positivity from the text messaging for the screening, but that there was some concern by some of the respondents about not having the availability to get COVID tested themselves, but
Correct.
also not knowing the COVID status of patients and families, which it sounds like increased their anxiety as well. Do you have any idea why they didn't have availability for testing themselves?
So early in the pandemic, there was testing was a challenge throughout the country and throughout healthcare systems, irrespective of type of healthcare system. Nursing homes had similar issues, acute care hospitals, and so did home healthcare. We were no exemption. So there was a shortage of tests, and that was one of the biggest challenges we faced earlier. And it certainly raised the anxiety of home health aides, because not knowing what the COVID-19 status of their patients was as anxiety provoking as not having access to the tests themselves. And it further heightened their sense of feeling all alone because of the fact that there was a strong message sent out by our participants that their voices weren't heard, right? Their voices about the anxieties they felt and the needs they specifically had in being, stuck in a room for 12 or 10 or 6 hours with an elderly patient and who may have been hospitalized 2 days ago, but yet you have no idea if they were hospitalized because they had COVID or not. In addition to other challenges that you navigate when you provide home care services, right? You may be in a home, although there's a pandemic, and you hope that the patient can put a mask on, but when you're a home care provider, you can't really force your patient to wear a mask. And they also had challenges with patients who were just by the aging process and other physiological changes probably could not hear properly, and really mandated sometimes that the aides take their masks off. And these are boundary difficulties that are constantly negotiated and challenged when you provide care in a home health care setting, when you're actually in the
And that's a great phrase, boundary complications, because a lot of, like you said, a lot of the patients disliked the masks, or hard of hearing patients couldn't understand them as much. And not only do you have troubles with PPE inside the home once you get it. You mentioned too that they had troubles getting it outside of work. If you work 12-hour, 15-hour shifts, however long in their home, and your office where you get the PPE closes at 5 o'clock, how do you get your PPE? How do you manage that situation?
Right.
And the phrase that kind of haunted me in here, HHAs lived in constant fear. I can't imagine the anxiety of not knowing whether or not you're going to have the PPE. And then when you have the PPE, are your clients going to, quote unquote, allow you to wear it? Because like you said, those are boundary complications. They may not necessarily be trained to draw that line. That's hard.
It's hard. And it's even harder to draw that line in a patient's home.
Right.
Because one thing we have to remember is that when you provide home care services as an aide, as a home health aide or a nurse, you're a guest in the patient's home, right? So there's a limit to how much you can actually be persistent and how much assertiveness. That role negotiation is something that's constantly being navigated. And it can happen even with higher levels of trepidation for home health aides who were, yes, working during the pandemic, but also remember, do a highly demanding job for very little pay. And there's always that anxiety that's present of the need to do the job
for very little pay and having to use some of your own money to purchase the supplies necessary to clean and keep yourself safe. And one of the other comments in the paper that struck me, it was like hell going to work every day. It is difficult because every day you are thinking and you want to know if you are contracting something. It was torment. It just broke my heart.
But it was. It clearly was. And one thing that is important to note is that these are low-income, hardworking, committed employees and important as components of the long-term care system, and many relied on public transportation. So while some individuals who have higher paying positions may have the luxury of being able to work remotely or work from home or have more hybrid formatted jobs where when they do not have to rely on public transportation, many home health aides relied on buses and trains. And with that high level of anxiety, really still had to get on public transportation, knowing that by going to work, they were
right.
putting
Yeah,
themselves
they don't
at
have
risk.
if they're using public transportation, they're not in their own car and insulated. So yeah, public transport would keep you at a higher rate than other healthcare workers.
Yeah. One other thing that struck me as well was one of the respondents saying they weren't considered first responders. So I think probably there are some differences in opinion in what is considered a first responder, but these are frontline healthcare workers, as you mentioned, that are integral, essential, critical to caring for patients who have to remain in their homes. So to me, that was mind blowing. And that must have been a huge blow to their confidence and, their overall self-esteem in working in this role that is, like I said, so critical. Any thoughts on, that situation?
There was a clear concern through the perspectives of aides that while their peers, such as certified nursing assistants who worked in the long-term care system, like nursing homes or in hospitals, received different types of bonuses or extra pay increases during the specific to working in the pandemic, hazard pay. Home health aides shared that they did not receive hazard pay early in the pandemic, although they did similar kind of work or even which was even more tasking because when you work in a patient's home, you have very limited support or backup. And that was really discouraging for many because there was clearly extra expenses associated with working in a pandemic, but that's something that happened across the board. And much later, some organizations have provided that much, I know, hazard pay to home health aides. It's just a big concern of feeling like the last in line most of the time. That was really very common across our interviews for the home health aide workforce.
It's very sad.
Yeah, it kind of broke my heart, like I said before. Well, I know I could talk to you for several hours. I've got so many more questions, but I know we're starting to run out of time. So let me ask one more. Do you have any statistics on the transmission of COVID from patient to healthcare worker or home health aide, or vice versa in those settings?
To my knowledge, there isn't specific data related to transmission between home health aide to patient in the home health care setting.
That there's just not any data gathered, basically. Gotcha. Okay.
Not
Yeah.
at this time. No.
Yeah, I think that would be really interesting, especially, thinking about the concerns of lack of education, lack of supplies, lack of PPE, fighting those barriers with the patients around wearing masks and the patients wearing masks and all of those things. I think that would be really interesting data to get down the road.
The paper just struck me too, like how many complications there are inside of the home, like not being able to socially distance or go to the bathroom to wash your hands because you're afraid somebody's going to fall, which means you can't really go to the bathroom yourself. And it poses a lot of problems. It's such a unique situation that home health aides are in, that inpatient and most outpatient hospital setting workers just don't have.
Correct. The challenges that they have to face are really significant, and we remain very thankful for the ability of many aides and the time they spent working during the pandemic, and continue to remain very grateful for their courage doing very good work.
Yeah, absolutely. Greatly appreciated. All right. So I think we're going to wrap things up. So we would like to thank Dr. Osakwe for speaking with us today about this awesome paper and about the home health aides and the struggles that they faced. Amazing information to have. And I think that more research like this should be done, because I think this is an area of concern, not even necessarily with regard to COVID-19, but just in general in how we're caring for our home health aides and giving them what they need to provide the care to our patients out there. So really interesting and greatly appreciate you being here.
Thank you. Very happy to be here to discuss new ways to move things forward for home health care, especially in terms of information management and the pandemic, and better utilizing and integrating our home health aides in the home health care system.
Well, thank you for joining us today. We are Nikki Shore and Jesse Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business. To hear other AJIC podcast episodes and to access information about this podcast in the field of infection prevention and control, go to our website at agicscienceintopractice.org. That's AGIC, scienceintopractice.org.
AJIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology, with input from the APIC Research Committee and Pat Stone and Jean Brandt at AJIC and APIC staff, Lisa Tomlinson, Liz Garman, Bobby Gulshan, Chris Ruiz, Kelly Lynn Russell, Sylvia Quevedo, Kaylee Deaton, and Christine Miller. We work in partnership with Human Factor and audio tech Blake Alton.